Hello, everyone. I think more people will slowly enter the meeting as we start, but I think it's time for us to begin this edition of Community Talks. So, welcome, everyone. I have the honor of presenting the February edition of Community Talks. My name is Larissa Celis. I am the communication manager of LerioS, and this month we have a very interesting topic. We have some very interesting speakers as well from Uganda. This edition will be about improving adolescent sexual and reproductive health through a participatory parent-child communication intervention in Uganda. So I said it already, we have some very interesting speakers from Uganda this month. Before we give the floor to our speakers, I would like to ask everyone to make sure to mute your mics, as this will improve the quality of this talk, and also to turn off your cameras, as this will improve the connection speed. This talk will be two parts. First, a presentation by our speakers, and secondly, we will have a Q&A discussion where you can ask your questions directly to the researchers. If you have any questions throughout the presentation, feel free to add them in the chat. We will keep note of them, take note of them, and we will discuss them afterwards. All that's left for me to do is to present our speakers. I would first really like to I'm really glad to introduce Professor Viola Nyakato, sociologist and gender expert at Mbarara University of Science and Technology, and also Professor Suhila Abedou, public health and primary care professional at Ghent University. I have heard that there are more experts from the team in the chat present who will possibly answer some questions afterwards. So all that's left for me to do is to give the floor to our professionals. Take it away.
Yeah, thank you so much, and thank you for your kind introductions. I am here to present to you an intervention that we implemented in Uganda, and it is on parent-child communication. And like the title reads, it was implemented using participatory approaches, as I will be explaining. And I am presenting on behalf of a bigger team for the project from actually four institutions: the University of Ghent and the International Center for Reproductive Health, and Viril University, Brussels, from the Center for Expertise in Gender, Diversity and Intersectionality. And then in Uganda, it was us at Mbarara University of Science and Technology, and then Makerere University. So this is the team. In the pictures, there are three members of the team. Professor Christine Michelsen was the main principal investigator until last year, when she moved from Ghent to Leuven, and she's still a member of the team, and she was leading this project. And then Elizabeth Kemgisha from Mbarara University and myself. Those are the three people in the picture, but we have many other members of the team. In Uganda, like I said, we have teams from Mbarara University and Makerere University. And then we also had two PhD students who are on the sandwich program studying at Free University of Brussels. And then University of Ghent, Achen Docus is under the supervision of teams from both universities, all the universities participating, but she's working with the main supervisor is Professor Gilly Cohen, and then Cecilia at Kwasa, the supervisor is Sohel Abdul, whom I have as a co-presenter. This project, we are actually very, very grateful to VirOS. This project is one of a kind. It's a project that draws on the evidence for a previous team project that we had implemented between 2015 and 2019, which was also an intervention project where we interviewed in a baseline 1,096 young adolescents, that is aged between 10 and 14 years, focusing on their knowledge and experience, reproductive health knowledge and experiences. And the project was undertaking the comprehensive sexuality education strategy to improve knowledge about reproductive health, but also to prevent adverse effects of reproductive health challenges. So one of the evidences that came through was the sources of information that young people get for their reproductive health knowledge and the different effects it has. From the baseline, we found out that a third of young people, the very young adolescents, access their information about growing up and reproductive health from media, and very, very few accessed information from school or their parents. And also in the same study, we found out that the young people who accessed information, however little that is related to reproductive health, if they had accessed that information from their parents, or they had ever talked about any topic with their parents that has to do with reproductive health, like pregnancy, sex, and menstruation, all those number of projects, they were not exposed to risky sexual behaviors like early onset of sex, but as well as being at risk for sexual harassment and abuse. So that was the motivation for writing the follow-up study, the 2019, which we have called the 2019-2024 CPAC project, which is a parent-child communication project, that's what we call it. So the aim of the project was to improve young adolescents' access to comprehensive sexual and reproductive health information by improving communication capabilities of parents and guardians in rural southwestern Uganda. So this was based on the fact that to be able to receive accurate information about SRH, parents need to be enabled, their capability to communicate. So it was also a communication intervention for targeting reproductive health. So that's the background, and that's how we came to start the project. I know that we are diverse in this community talk, so I wanted to give a brief highlight of what sexuality education is in Uganda. Like it is with most traditional African societies, the family plays a cardinal role in communicating issues of growing up and sexuality. And mostly it is not the parent. Traditionally, it is not the parent who is expected to communicate. For some of the institutions and some cultures, it is the aunties and the uncles, those who come from Uganda in this community talk. You could have heard concepts like Senga Koja among the Waganda in central Uganda, and then the Western Uganda shrinkers. So this really took a very important role. And most of the times, the sexuality education and growing up was mostly targeting girls and to coach them about their gender roles, and as well as preparation for marriage. So that's the kind of history and background. And then culture and religious leaders, and as it is even in the present, really inhibit discussion and open discussions about sexual and reproductive health for a number of reasons: social order, different roles, fears, as we shall be seeing in the results. Of course, Uganda is also on record for having taken a long time to provide guidelines and policies as far as sexuality education is concerned. As a result, there is low efficacy of parents and caregivers in giving and being certain on the timing, on the topic, on the process of sexuality education and what has to be talked about. And this continues to impede and affect the parents' ability to really be very effective and efficient as far as being the primary role and primary caregiver, primary source of information about growing up and other reproductive health topics. The project was set to do a number of things, the strategies and the anticipated results, which we shall see later in the evidence that we are going to provide to you. as the findings of the project, because really the project was supposed to end last year, but it was extended for a number of delays that were also as well associated with the implementation that was affected by COVID-19. So one of the main strategies was to improve parent young adolescent communication on SRH in rural southwestern Uganda. And this was achieved through training parents on communicating easily sexual and reproductive health topics with the young people, and improving community support. And I'll be explaining about the project. How did we improve community support? And the other one was to have to participatorily develop and implement and as well evaluate culturally an accurate and culturally sensitive sexual and reproductive health intervention. And this was going to be achieved and has been achieved through developing a parent young adolescent communication guidelines, which we have developed. I'll be explaining them. And then if I have an effectiveness study and process evaluation of the project and its processes, and then participatory assessment of the current parent young adolescent communication practices. I also explained that, and the systematic review and about the different practices of parent-child communication practices, and also to create a community support system through a community advisory board. I also explained how it worked. And of course, at the end of it all, it was institutional support and capacity development for Mbarara University, and to continue to build the capacity for sexual and reproductive health, young adolescent reproductive health research. And we have literally achieved most of these strategies and outcomes, like the expertise in adolescent health communication, community engagement, mentorship, and training of young people, and improving young people's services. So this is the project overview that also draws on the objectives and strategies. First and foremost, from the previous project, we had what we call a community advisory board, because for people who already know about Uganda's experiences of comprehensive sexuality education strategies and the different activity and the different the context of comprehensive sexuality education in Uganda, it's a sensitive topic that you want to do it in a way that you build on the social systems that will enable you and support you to work. So from the previous project on comprehensive sexuality education in school, we had established a community advisory board, and we transited with the same community advisory board that had representatives of the Ministry of Health and Ministry of Education. And in this current project, we added the Ministry of Gender because of the topic. The previous topic was entirely in school, but this topic was also in the community, and for all community activities structurally in terms of roles and responsibility of ministries. The Ministry of Gender, Labour and Social Development takes the primary responsibility for activities of communities, and Ministry of Education activities of education, and the Ministry of Health being a technical topic on reproductive health. So that's how we included them. And then the teachers, we had them previously, the parents, we had them previously, religious leaders representing the primary, like the most common religious sects, the Islam, Catholic, Church of Uganda, which are and then Pentecostal. So we try to represent the religions, but on the new project, we added the children themselves. So that picture shows one of the sessions led by the community members. So this constituted a community advisory board that reviewed our proposal, our strategies, our objectives, the tools that we used, and they gave us feedback. So we discussed both the science and the community issues as far as the study was concerned. So we first conducted a baseline, and then here we had dyads. We had we enrolled a parent and a child, and this child had to be between 10 and 14 years. So when we enrolled a parent, we enrolled a child. So the same tool that the parents responded to, the same tool for that the child responded to, because we're testing congruence later, as I will be explaining, and to see the level of communication, the practices of communication, and what do parents say and what the children say. So we had for the baseline, we collected data between January and February 2020, and the mean age for our respondents, for the parents, it was 44, median age was 44 years, and for the children, it was 11 years. Female participants were more than the male participants among the caregivers. But we had more boys as compared to the parents, when the parents of the boys. And then the intervention was conducted, and later we had the end line. And in the end line, we focused on looking at improvements in communication and the factors that led to the improved communication. So we had an intervention that was in between the baseline and the end line, and the intervention focused on building the capacity to communicate SRH topics, and then policy engagement. So policy and community engagement. So those are the elements that were mostly in the intervention, as I will be explaining. So this is the main context also as well. That was the best. I've already talked about the baseline. And then, of course, it was during COVID-19 pandemic. We take it as an opportunity, because also that's when parents were really more with their children, and they had quite a lot of concerns around the risks as far as SRH is concerned. So this was an opportunity for us, that children were at home with their parents because schools were closed, and also the parents were available. So they had real-time experiences that they shared during the time of the intervention. I've already mentioned study populations were young adolescents and their caregivers. Why we use the word caregivers is that some of these people were not their biological or even adopted parents. Some of them were grandparents, others were relatives that were staying with these children. As long as the household had a child between 10 and 14 years, we enrolled them into the study. And I've talked about that the study had a dad, the caregiver and the parent. And then, of course, we for data collection, we had computer-assisted surveys. We used CoboCorrect, and we used tablets to collect the data real time. But also, we had qualitative participatory methods that we used to timelines and community surveys, community entry experiences. So the communities, and then like I mentioned, we had a CAB, but also we had an advisory committee at the community level that we shared with about the strategies, mobilization, and then they would advise us, and they mobilize the community for participation. And also the community selected people who are trained as implementers of the intervention. They were selected and they were selected at the community level. And then also the teachers who were involved, the parents, the children who were involved, all of them, we engaged the community to select them. And of course, we had quantitative data. We conducted linear regressions and then thematic content analysis for the data that we collected. And I've talked about the community advisory board. So we conducted engagement, like stakeholder engagement meetings pre the study, and explained this is the study that we are going to conduct. And also we had a closure meeting where we brought members of the community and community leaders to really reflect on the findings of the study and what they mean. So the community leaders included local political leaders whom are called councillors, chairpersons. These are local governance structures, village health teams, people from village health workers in Uganda. The village health workers are really very instrumental in working at community level, and they are very important. Then the religious leaders, and technical level, we had inspector of schools, community development officers, and teachers. So, and at the end, when we had the end line, we had what they call most significant change stories. Here we collected in-depth interviews about the different experiences of the interventions, and here 37 participants shared the experiences of the interventions, and there and focus group discussions, individual interviews. So that is a whole like the people that were involved in the study process. Here we come to the findings. I don't want to miss out on the findings. The most importantly, like I've said, those are the numbers of the people that we were the parents, caregivers, 218, And then the mean age, I've already talked about it, and the number of young adolescents in the household were 2. The average number is 2. And when it comes to, let me see if I can, when it comes to some of the parameters for communication that we focused on, one of the findings in the baseline was like there was moderate connection among the parents and their children. And then there was a negative attitude towards younger people having information. You see moderate connection mostly among women, but also when you see among female caregivers, and then negative attitude towards SRH information. They are the primary, but also they hold the higher levels of negative attitudes towards SRH communication. And then there was also moderate knowledge of SRH topics, key topics that we talked about. But the comfort of discussion of some of these topics were also higher among the women. So these are the key parameters of communication that we looked at: connectedness, attitude towards the topic, and then the knowledge and the comfort to talk about the topic. For some of the topics that people had knowledge about, that level of SRH communication and knowledge and communication, one of the most talked about or communicated topic is HIV/AIDS, followed by sexual violence and reporting, handling sexual pleasures, but the least talked about is sexual conduct, condoms, birth control, night emissions among the boys. So these are the topics that also another talked about topic is actually body hygiene. So that's one of the other topic that is highly talked about: body hygiene and general topics about the body. So what about the correlates between the level of communication and how significant is this? So we found that increasing, because now I'm comparing the baseline study and then now the end of the, So increasing SRH communication actually improves the level of communication. So it builds the confidence. So increase in SRH communication leads to increase in comfort of SRH communication. So that we were able to prove that in this study. And when it comes to the end line, what about comfort? We also find that comfort of SRH discussion increases with increase in the number of young people in the household. So the more young people they have in the household, is the more they can talk about this topic, but also the comfort to communicate is affected by one's religious values. So this is one of the, I'm picking on the key highlights of the issues that come out in this study. So what was the impact or the contribution of the intervention that we had? We can say, or we can comfortably say that some of the topics that were really, really very difficult to talk about, like wet dreams, condoms, pregnancy prevention, sexual conduct. So you see that after the intervention, this was an intervention that we conducted, and we had different community sessions on particular topics. And these topics were ranging from talking about parenting and the roles of the parents. And then we're talking about these topics clearly, what they mean, how they are talking about, what are some of the community practices about this topic. And what we would do would train the community trainers about the process of talking about the topics. And then we would hold community sessions led by community members. So, and then you see that really the intervention had a positive contribution. The blue is for the baseline, and the orange color, if you can see the same colors as I'm seeing, shows the end line, the end line. And so for every key issue or key variable for sexual and reproductive health, you see that there was really a positive contribution to the parents, to their ability to talk about these topics with their children. So when we trained, they went back and put it in practice. So these are some of the what can I say, expressions about the experiences of the intervention and and what it meant for the different participants. And like I said, we had different levels of evaluating. So we had the quantitative, whereby we had the surveys back to the dyads, the people that had participated in the study. Then we also went to collect stories of the most significant change stories about the different experiences, and then the domains of change, and then we're looking at what are people picking on, and what are their thoughts, and what are their qualitative experiences. So these are the expressions that someone says, my thoughts about children engaging in sexual acts changed after attending the sessions about STDs and HIV/AIDS. My children had started engaging in those acts, but I didn't take time to talk about these issues. So you see that issue of time, that parents say that we need time to give to our children. And I also told my children that it's possible to get HIV/AIDS. And then also, I also, from men, especially now, they have already started menstruating, they have already started menstruating. So they are talking about these issues. And then they also talked about issues of pregnancy, those primary concerns as far as SRH is concerned. I also told them that they can use condoms. They told that condoms can prevent them from getting pregnant. So these are some of the tough topics that we found that the parents confess that they can easily talk about them with their children after the intervention. And what about issues around comfort of SRH discussion? At the start of the training, I even would feel shy and would wonder how I would mention some difficult terms in front of my children. But now I feel I have the comfort. I can talk about this. So this is what we picked on. And one of the things that we have found out in one of the papers that has already been published is that one of the driving factor for communicating SRH, as even the little that they communicate, is driven by fear. So we also see that it comes out qualitatively as a key element. So fear is one of the issues that drive SRH communication from the study that we present. And the other factor that we are looking at is there like improved gender differences or gender issues around the issues of SRH. However, because of the study information, I had learned and obtained experience, and now talk to communities with my daughters without fear. So being a man, so you see, from the study, we had found that it's mostly mothers who communicate. So now the men who are involved, because we tried to encourage male participation, and like I say, the context of COVID-19 and that people were home made it easier for men to participate in these interventions. And so men came out and said, okay, I can be free and I can talk to my daughter. And also we had women who said, yeah, it has made it easier for me that I can talk about this topic. But also you see that in their expressions, issues of fear come out, issues of saying the bad conduct. So you see that those are some of the factors that we need to interrogate, understand better, and see how they even build the system of SRH communication in Uganda. So knowledge and attitude after the intervention. As a parent, I never knew that a girl of 12 years can go into menstruation. So you see also that the project contributed to improving the knowledge. So parents see their children as young, and they don't put into perspective age and physical development. So when they see their children, they see them babies, and they don't look at physical development. And of course, can also look at the educational background. If we look at the educational background, someone would expect that parents go, but these are parents who have not gone up, like taken higher levels of education, that they would definitely know that this is the topic. But also we also in Uganda, the context is that SRH education is limited, and although this was not the topic of our study. Always I looked at her as a child, but after attending the training, we are now sit together and talk about these things. I tell her that boys can impregnate you. So what you see in these narratives, they always bring out some of the key concerns of SRH and SRH communication. You hear fear, you hear HIV/AIDS, you hear girls and boys, bad conduct. So also these narratives tell us a lot about some of the concerns of SRH that we could pay attention to. So what would I say? What is the contribution of this study? We can say that we have a contextualized parent-child communication manual. We have a manual that we have published, and it has all the steps that we took to develop the training, the implementation of the training, the delivery of the topics, how we delivered them, the engagement of the community, how these topics were selected, and how important are they to the community. So the manual is contextualized, and it is important that we have some of these issues that are really contextualized. We have contributed the establishment of an adolescent clinic, and my colleague Liz is in this picture. So the adolescent clinic has, it's the first of its kind at Mbarara Regional Referral Hospital in partnership with the pediatric department and the research team. And the clinic is now seeing quite a number of young people who didn't know where to go, even when they have their simple topics and simple questions. So it is a contribution we can say that we have, and then we are looking for different projects to contribute to the establishment, because it is it's not yet like an institutionalized structure, but it has a lot of support, and the pediatric department has contributed a nurse to oversee it all the time. We have volunteers, both visiting students and our own students. So we see that it is a service that was lacking, and then it is a contribution that is being made. Then we can say that young adolescent research capacity has developed because of the number of ongoing research that we have, and then we have the confidence, and also there's another ongoing ongoing projects that are supported by VREL. Also, we can say that the capacity for adolescent research at Mbarara University of Science and Technology for both research and training has improved. And then we have quite at a personal level and at team level, we have conducted a number of parent-child communication outreaches to parents, to students in the corner there who are having holiday, students going back to school after a long holiday. We had an outreach and called parents, and they gave us young people, and we talked about these issues. So we have conducted a number of outreaches. We also conducted an outreach in what they call this, an orphanage. And what was interesting for us for the orphanage is that these young people are growing without their parents, and who takes care of these young people and their reproductive health needs. So the caretakers of the orphanage allowed us to come in and talk to young people, and the testimonies and the letters and the cheats that these young people wrote to us were really, really very humbling. So different outreaches that we conduct for people who have known that we have these skills and the capability. So we are also contributing to the National Parenting Agenda Network. One of our PhD students, Cecilia, I think she's here, she has engaged in quite a number of meetings at the National Parenting Agenda Network, and the evidence is being used and transited, and the policymakers are finding it easy and comfortable with us for us to discuss with them about some of these issues. These are some of the publications that we have so far from the study, both the baseline and the end line, and they talk about different topics, because we already have a paper that evaluated the project and its process. And then we also have a paper already on the narrative stories from most significant change, stories that we collected from parents. And then the trends on comprehensive sexuality education. This was from the narrative review, reviewing different literature. And then another study on level of comfort from the baseline that shows that the level of comfort from different parents, and then the gendered experiences of parent-child communication from our qualitative and participatory data that we collected. These papers are led by my PhD student and one of the master's students that was coming from Ghent. What have we learned? We can say that our lessons are that parent-child communication is associated with a level of comfort with a topic. So comfort with a topic is an important element when it comes to parent-child communication. So for all interventions that have to do with parents and improving their ability to talk about sexual and reproductive health with their children, we have to work around improving their comfort with a topic, because culture and behavior and different exposures affect the comfort that we have and the different experiences that we have. And this affects the parents' ability to communicate. Sexual and reproductive communication is also, in our context, is driven by fear and tension regarding the negative outcomes like HIV/AIDS and teenage pregnancy. So it's a driver. Fear is a driver, and tension. The different experiences of HIV/AIDS that the country has had and families have had, teenage pregnancy and its negative consequences, all that drives parent-child communication. And parent-child connectedness is also an important, when we improve the parents' connectedness with their children, then it also improves SRH communication. And also comfort improved by SRH knowledge. So what the parents know improves the comfort that they have with. So what are we doing? What is our future direction? In the picture is the cover page of the manual that we have published from our study. I must say that we use materials from different agencies, different organizations. So it's not that we use different materials on communication, SRH, parenting. So all that that makes the manual very extensive. So the future direction is really to seek support for the adolescent clinic for both research and service. And then there are planned follow-up studies. We are going to write a team project in partnership with the University of Cape Town and KU Leuven. And this is for the work that we've been doing with Professor Christine Michelsen and a colleague from Cape Town University. They are interested in translating this manual into another setting, so an urban setting. And I've said we did it in a rural setting. What kind of experiences can we have? So we have gone to the level of being allowed to write the team project, and so the writing process is on. So, and then I met someone who is interested in writing a postdoc focusing on teenage pregnancy and school policy, which is one element that comes out very clearly. Pregnancy is an important factor when it comes to SRH communication in Uganda. And of course, we need to see like the uptake of this parent-child communication manual. Yes, we know the Ministry of Education, Ministry of Gender is working on parenting guidelines, and so we would wish to see how the process of translating this manual being used in different by different communities and different agencies and different people. So those are the future factors and direction. Thank you so much. I end there for a question and answer session. Thank you.
Thank you very much, Professor Nyakato. I think I speak for everyone when I say that this is a very interesting and very relevant topic. And I can see that as well by the number of questions that have come in. So I suggest I will just start with the Q&A session. The first question that came in is by Tosa Cheru, who asks, is that negative attitude about the topic of SRH not confounded with other factors? But I think you kind of already answered that question. I think if you can briefly recap the answer to that question.
Yeah, actually, I saw that was the first question that came in. But negative attitude also is driven by the experiences of the negative SRH outcomes. Like I've said, issues are around teenage pregnancy and all the negative factors that come around it. HIV/AIDS and other experiences of SRH outcomes that are really very negative. So that one also affects the attitude. I think that's what I said. Yes.
All right. Another question that has come in was by Nicoline Oise from Cameroon, who says that their organization called Pathways for Women's Empowerment and Development, they are envisaging a similar exercise and would love to have an opportunity to collaborate with you, which is very nice, and ask for you to share your data collection tools if that would be possible. Maybe I can forward the contact information of this person to you.
Okay, it's okay.
Would be very interesting.
Yeah.
Another question that has come in is by Ellen Mitchell, who asks, were there any refugee or migrant or independent adolescents in the sample? And if so, did you observe any differences in KAP?
Okay, we didn't have refugees in our sample and other special group interests as in our sample, because the community where we implemented the study was it's a village settled, and they do their daily, because if you go to up country and it's a village, people are really much more settled than in the urban, where you can easily find it will be interesting to see like the project that we are writing with the University of Cape Town, which is in urban setting. That one would bring us a diverse community as compared in the rural, where communities are much more settled. So we don't have that experience, actually.
All right,
Yeah.
okay. The Nicolas Wazé also asks, what role does cultural barriers and taboos play in inhabiting parent-child communication on SRH?
Yeah, I don't know. Cecilia is my patient, so I see her around. If she wants to say something to answer, she can. But let me go ahead. I think that's why I say I started with a context, because the roles of parents are different as far as SRH is concerned. So parents, that's why their comfort is affected and their confidence to communicate, because it's not expected. So culture has an important effect. Culture really affects the role of parents as far as SRH communication to young people is concerned, because there's an established system and order of expected roles of a parent, and one of them is not communicating SRH issues. But of course, I would have talked about the changing family structure, where these aunties have become in urban areas. They have traveled. These children even have never met them, so they can't play a role of being the ones to communicate. So caregivers and parents will primarily take up a role because of the changing family structure, but culture has an important role that it plays. Yeah.
Okay, great. I don't know if anyone from your team also wants to add to this topic.
Cecilia, are you there?
Yes, thank you so much. I think this was very interesting. Dr. Viola has mentioned most of it, but like she has said, their culture is more or less like an underlying factor that affects discussions around sexuality, because of course we are in a setting where open discussions around sexual and reproductive health is just something that is novel, that is starting. We traditionally openly talking about sex is more or less like a taboo, and more or less talking with children. For example, young adolescents in this sense are deemed to be still very, very young to know about these things. And of course, the assumption that we are in a culture where we believe that these children are maybe are naive, don't have any of this information. As parents, that's what parents think. So all this influences how parents are able to communicate or not to communicate with their children. And also the underlying factor, which mainly came out very much, comfort. So because of the cultural issues, parents, of course, will become uncomfortable bringing out these issues to their children. Thank you. Over to you.
Well, I see another question that kind of relates to what you just said. Someone else asks if there were spaces where you noticed where parents found themselves more comfortable discussing SRH than in other spaces, if you noticed the difference.
Cecilia, you want to say something? Can go ahead.
Maybe I can. I would say that we didn't really go into learning about spaces. Maybe Viola, you'll add more if we have something from the qualitative side about the spaces for talking about SRH communication. But for this study, the main issue around comfort was the relationship between the child and the parent, working around having a parent have a good relationship with a child, and that we saw as the key issue, that a key factor that would improve the comfort, because we realized actually, as other significant change stories indicate, that the relationships between the children and the parents were really, really strained, and working around those relationships would help address the comfort of these parents. As far as spaces are concerned, I wouldn't really give much detail. Yes.
Yeah, we don't have detail because, like I said, the context also was that it was a much more settled community, and we're working with parents coming from their homes, learning about the topics, and then and trying them out. And actually, they tried out a lot of them. But like Cecilia said, the relationship, which is actually strained by the fear of the negative consequences, like parents are driven by the fear that the girls will be pregnant, the different experiences of HIV/AIDS and the tensions around HIV/AIDS, because communities have really, really bad stories around HIV/AIDS and losing of relatives, and the cost it takes on the family and the stigma about HIV/AIDS. So all those are factors that come into play and compromise the parents' comfort, and then they like for them to be able to take a primary role. Yeah.
All right. Thank you for elaborating on this question. If I'm correct, I saw someone raise their hand. I think it was who did I see? Yes, Mr.
Aisha?
Jagati. Yes.
Mm.
You can ask your question.
Okay, it's me. Okay, thank you very much for this good presentation. And I'm calling from Zimbabwe, and the beauty of the presentation is that it appears to be applying even in the context of Zimbabwe. So my question is, since this project has been done in a rural setup where tradition and culture are so much respected, are we not also going to colonize the rural cultural norms and practices by introducing a board like community advisor board? Because I also want to think that there are some cultural institutions, like in our own context in Zimbabwe, whereby we have Dare, whereby it's a main forum whereby young boys during the evening, they sit around a fire and they discuss these issues. Are these not new, institutions or frameworks going to colonize or obliterate the local traditional frameworks? And also another question is, this question is coming from the idea that we all know that the challenges which we are now facing from a SRH are increasing, meaning that the assumption might be previously we used to have some traditional regulations which were better, and if we happen to tap from them, we might also realize or get something better, although there is this overwhelming forces from global. And then the last question is concerning about the questions which were being asked the same people, the parents and the children. And we used them maybe to assess, to make a conclusion. Is this not also going to be insensitive? Because we all understand that from the rural setup, the elders, the parents and the children, they have these different spaces through which they are comfortable in narrating their own issues. Then the last maybe a issue that I would even want to highlight, it has also been noted that especially among us as men, We all know that we always want to enhance our sexual prowess, but we don't necessarily want to be known. But when it is advertised or displayed, we just take it. We just find ourselves accessing the information so much easily than if it is advertised openly to the people. Are we not losing some traditional traits that we need also to promote in order to comprehensively address this issue of ASRH challenges? Thank you.
Yes, a lot of questions. I don't know, Professor Nerato, if you want to, yeah, I think you wrote them down, so you're writing them down. Yeah.
Yes. Yeah, thank you so much, Maya, for your comment and concern. And I want to say that one reason why we worked with a community advisory board that was cross-sectional in nature, that represented the key like institution in the community, was that to first of all agree or understand, and do we need a parent communicate SRH issues and why? And one of the topics that we had in our intervention is parenting and then communication. So it's not that the intervention was comprehensive in nature, that it was not looking at only the SRH topic, but it was looking at the roles of the parents, is communicating SRH. Like, for example, what topics around hygiene, topics around risks for sexual violence, topics around pregnancy. So that what role does a parent play? And so by working with a community advisory board that had already members of the already established structures in society, is that we first had to look for the relevance and the importance. So I cannot ideally say that we are colonizing the established structures, but in any case, public health interventions have to come in to deal with these issues. And where do you start from? From the previous project, if you started, we have seen from the previous project that we had from schools and the different information that children get from school, we found that children who have information from parents have a higher chance of being protected from sexual and reproductive health challenges. So parents really, we had a lot to play, and we have a responsibility as scientists and as researchers to build evidence on some of institutional structures that have a role to play. So that's what I could say. But I think I don't say that the global forces on some of SRH topics. Of course, there are different issues around global like the global agenda as far as SRH is concerned, but that doesn't take away the responsibility to build the evidence that is required for us to have a basis for some of the national strategies for which are going on. Already, the Ministry of Gender is working on a strategy for improving parenting. And one of the issues on parenting is SRH communication, and be able to talk to our children about growing up. So it's a contribution that the study contributes. Yes, of course, we have the same context when you talk about the parent and the child. So because we had to, for us to be able to have, we couldn't do a study only for the parent and only for the child. So having a dyad helped us to really know where to start from, and what do the children know, and what do the children get from their parents. And so that's how that's the methodological decision that we made, that is justified, that we needed to have put the parents and the child at the same level as far as comfort is concerned and knowledge is concerned. And yeah, so that is what we did. So the other one was I don't know if I've forgotten something. Yes. So of course, young people have different spaces, and increasingly young people are finding their information in media. And we have found out in our study, in the previous study and the current study, that media information is more destructive than the information of the parent and from the school. And Uganda now is still waiting to implement a sexuality education framework, which was approved in 2016. And there are contentions, of course, institutional, cultural, religious, political contentions around the topic and the topics and what to talk about. So the schools SRH is being practiced on topic and subject level, but not a comprehensive strategy. We had previously had a PSA, which was a presidential initiative for preventing HIV/AIDS among young people, and it had quite a number of successful stories. So the leadership of the president there had moved, but institutionally, we are still not yet implementing the sexuality education framework that Uganda would have wished to have. So some of this evidence helps maybe the country to prioritize and looking at the different institutional frameworks. Yeah, I could stop there. Yeah.
All right, I see someone still raising their hand, and I also have two more questions in the chat. I suggest that these are the last questions that we answer because it's actually already time, but there are a lot of interesting questions being asked. Maybe we can start with Ms. Nicoline Wazé, who still has a question.
Hello, everyone. Thank you so very much for giving me the floor. I'm Nicoline Waze. I'm joining in from Cameroon. I just want, it's not a question, just to throw some light on the question on comfort zone. Because, by the way, I am a gender and development specialist in Cameroon. And I thank Professor Viola for actually answering some of my worries lately this morning, because we are actually working on a model law on gender-based violence in Cameroon. And with the ongoing crisis in Cameroon, sexual and reproductive health right access has been like very, very limited. And we are trying to do a similar work, but I didn't know how to approach it until she gave me all the answers this morning. And from the preliminary work that we've done so far, comfort zone is because those cultural barriers, people are brought up to think that talking about sex with your children is the type of cultural indecency. But then we are trying to identify where are those spaces where even the mothers and the fathers, they feel comfortable talking about. I've also worked with the courts in Cameroon entertaining divorce cases. And you work on a divorce case for 3 years. You never know what is the cause of the divorce until when you corner a party, you know that the cause of the divorce is coming from the bedroom. And people they are not brought up, they don't have capacity, awareness has not been created to talk about those things with relative ease. So now we are trying to encourage women, where are the spaces where they feel comfortable to talk about their sexual life? Because if they cannot give to their children what they don't have, if they cannot communicate about their own sexual life, they cannot go communicating about the sexual lives of their children. So we are identifying some social spaces like age groups, like social gatherings, and all of those places. Women feel at ease because when they are with their age mates, with their friends, with their colleagues, they feel at ease to talk about how sex is practiced in their marriages, and some people can help them, correct them. And with that capacity built in those spaces, they can easily communicate with their children. So I just wanted to bring a small contribution to the beautiful and wonderful work that Prof. Viola has presented this morning. Thank you again, Prof. Looking forward to collaborating with you and having this work done also within my Cameroon perspective. Thank you so very much.
You're welcome.
It's always nice to see projects inspiring each other. So thank you for your addition. As I said, there are two more questions by Francesca Benson in the chat, and I suggest this is the last two questions that we discuss. The first question is, to what extent does unresolved trauma from the parents due to external circumstances contribute to SRH?
Yeah, thank you so much. I can't concretely comment on this because mental health, because some of the topics were actually chosen by the community, and mental health is one of the topics that the community requested us to include in the intervention, in the topics that should be talked about. So we included it, and we included it, and some of the topics were in group sessions, and also we had community sessions. So it's one of the topics that we included in the larger community gatherings and sessions that we have. So and so we could see, but we could find out that that we could see in our data if the parents, because we didn't explore into the parents' previous experience, for example, like sexual violence, if it could have influenced their ability to talk about these issues. So I cannot concretely talk about it, but actually when we were exploring the community and asking them to include some of the topics that they feel shouldn't be left out, mental health is one of the things that they highlighted for the young people, but also for the old people. So that's what I could say. I don't know if Cecilia, you had something that you have come across in the data, but not at this moment for me.
Not really. We don't have, I wouldn't add much to what you have said. It's all said from you.
Yeah, thank you.
Okay, and then the last question of today's edition, are there any cultural or societal barriers that hinder the access to sexual health services that you encountered?
Yes, we had quite a number, because our entry meetings are the ones which helped us to really be understood and be acceptable, because there was a lot of suspicion, religious, because we had to go step by step explaining. So we took a long time for entry, because when you talk about sex, they say, what are you going to talk about? Pregnancy? You cannot do that. Family planning, this is not the topic that we talk about. So, and sexual act, it's unheard of. So the cultural barriers are there in the expected standards, and that one we cannot deny, because any community has like expected standard social order. So we first of all had it in literature, and we had it in the previous study, because we have one of PhD students who really looked at the community barriers, and culture came out strongly as one of the issues, and actually have a paper on that. And so it came out clear issues of gender roles and the role of parents, the women being accepted to come even for the training, the roles of husbands. So the cultural barriers cannot be underrated, underestimated. They exist, and it is actually expected that you must deal with them as well. Thank you so much.
Okay, well, perfect. Thank you so much for all of the questions being asked. I think this brings us to the end of today's session. It is already 12:05 here in Belgium, so our hour is finished. That's all the time that we have left. I would like to thank very much our experts today, Professor Nyakato and Dr. Akatokwasa. Thank you so much for presenting your research today. I speak, I think, for everyone when I say that this is a very interesting topic. And with that, I would like to thank everyone here for their participation, for being present here today. Make sure to tune in next month, because in honor of International Women's Day, we actually have themed our next community talks about gender as well. This is also kind of about gender. So next month will be about gender as well. We will be talking about gender and climate change in Northwest Ethiopia, together with the University of Uganda, with Wageningen University, and the University of Antwerp. So make sure you tune in next month. And once again, thank you so much for being present. Thank you so much.